program today, and we have Dr. Abraham Mammen, who will be moderating the session for us. Dr. Abraham Mammen is the Senior Consultant in HOD Pediatric Surgery and CMS Head Quality Assurance Department from Astor MIMS, Calicut. Since our speaker has very limited time, I'm sure you all know about CAHO, and I hand over to Dr. Abraham Mammen to take the program forward to introduce the speaker and for the sessions. Over to you, sir.
Thank you, Lalu. Good afternoon, everybody, and welcome to this session on case-based scenario. Give me a minute to just introduce to you the speaker for the day, Dr. Sodzi-Tettey, who is the Vice President of the Institute of Health Improvement, IHI. He provides strategic, technical, and relationship guidance for the IHI's work in Africa, while also securing new business opportunities in that region. Prior to this role, he was IHI's Senior Technical Director, Africa, leading Project 5's Alive in Ghana to deliver a large-scale quality improvement project in more than 80% of the public sector hospitals and 30% of the Ghanaian sub-districts, contributing to a 34% reduction in facility-based child deaths. He also supported the design of a large-scale improvement initiative in Ethiopia. Additionally, he is leading IHI's ongoing support to the Liberian Health Ministry health system, rebuilding efforts post-Ebola. A public health physician, quality improvement advisor, and a fellow of the International Society of Quality in Healthcare, Dr. Sodzi-Tettey has also years of clinical and management experience in frontline district medical practice. Before joining IHI, he conducted high-level training and short-term organizations in various places, including Saudi Arabia, India, Ethiopia, Liberia, Nigeria, and the US. He serves on the governing board of Ghana's National Health Insurance Authority and the Council of the University of Health and Applied Sciences. Welcome, Dr. Tettey. Over to you for your presentation.
Thank you very much for the kind introduction, and I'm very glad to be here. I know that the CAHO platform is a very distinguished and a credible one, so it's always an honor to have this invitation extended to me. I would now share my slides and then speak a little bit about the Ghana project. You may or may not know about this project, but I'm hoping that the presentation is not just going to be about the project itself, but the project is just an opportunity to share lessons about what it takes to be able to implement projects at scale. Because in the Institute for Healthcare Improvement, there's a phenomenon that we describe as pilotitis, where people would implement on a small scale, get fascinating results, but are unable to scale up, are unable to achieve impact at the national level. So this project gives us a unique opportunity to be able to understand what are some of the frameworks that we use in our work and how can you apply some of the lessons that you can from your end. So it's about the project, but not so much about the project, some of the general principles. And you may be aware that this project ran for 8 years in Ghana between 2008 and 2015, funded by the Gates Foundation, and had a number of partners, including the Catholic Health Service, Ghana Health Service. It was independently evaluated by the University of North Carolina, and IHI ran it. At the time, Ghana was working to achieve Millennium Development Goal 4, that of reducing the deaths in children less than 5. And we said that we would use quality improvement methodology to accelerate these outcomes. So the question is, how did that really happen? Now, this is a scale-up of the entire project, as you see, where we had an initial phase of baseline assessment, starting small in 3 districts in the northern half of the country, codifying our learning and rapidly scaling up to all the 38 districts, roping in a number of hospitals in what you might call the third wave, and then coming up with some referral components. So by the time of national scale-up, we were working really across the entire continuum of care. And you see the exponential increase in the population that we are reaching. What I'd like to also draw your attention to is the number of quality improvement teams, where we started small with 30, but at the time of national scale, ended up with 709. And a bit later on, I will speak about the extent to which capability can be built in the health system. Cumulatively, we were able to reach over 80% of the public hospitals in Ghana and 30% of the districts. Now, this is the scale-up framework that we've used. So you would set up, you would build will, you would align priorities, and then there is also the thinking about a scalable unit. Now, that scalable unit is the smallest administrative unit. So it may be a health center, it may be a hospital, it may be the entire district, but you are trying to layer your implementation approach along the way the health system is organized. And so that once you learn about how things actually play out in terms of your methodology, in terms of the outcomes, then you have a sufficient degree of confidence that because you've implemented using the structures of the health system, you have a greater likelihood of being able to scale up. In the test of skill phase, you want to be able to implement in a variety of settings. So in our instance, for example, I talked about the 3 northern regions. I talked about, yes, the northern region where we started, but it was in 3 separate locations. It was also in the public sector and then in the faith-based sector. Ultimately, at national scale, we added 1 or 2 private sector facilities, but you test in multiple sites to strengthen your belief in the proof of concept so that by the time you go to full scale, you know how the health system is really going to respond. The Institute for Healthcare Improvement has a framework or some theory around how you can achieve large-scale impact or project success. And it talks about will, ideas, and execution, that you need to build will, create a platform where the need for the change is appreciated. You need to harvest ideas, whether it's evidence-based, publications, frontline stuff. You need to harvest these ideas at work. And then you need to resource the projects and create the real energy and the people who are available to execute. And when you have these 3, then you have a greater likelihood of scale. Also, there's infrastructure that needs to be in place to be able to scale up your initiative. So the question is, if you need to build well, how do you do that? And alignment is key, because if you go to a place where they have a certain set of priorities and you have different sets of priorities, it's always very challenging to be able to align. But if you get into a system where quality improvement is a priority, a system where reducing maternal and child health is a priority, a system where they want to promote the use of data for decision-making at the front line, as opposed to just transferring data without knowing whether it's being used or not, then when you situate the quality improvement methodology within that structure, there's a greater likelihood of success. Then we come to the matter of the methodology itself. And here you may be aware of the model for improvement, which was really the guiding model that we use, because at the end of the day, when you have done your process analysis, when you've identified your direct and indirect causes of mortality and the various gaps, how do the teams, the quality improvement teams that you formed, how do they interact and how do they intervene to be able to improve those processes? And we use the model made up of 3 questions and a rapid cycle of improvement, so that they would set ambitious aims. They would have a measurement framework to know what are the key processes that are changing and the key outcomes. And they would be able to make specific changes within their health system to test. And we talk about testing because you would test on a small scale, learn from the effect, challenge yourself a bit more, and then you would implement at scale. And also, we use the Improvement Collaborative Network. And here, it's a peer learning network of similar facilities. So whether they are hospitals, whether they are health facilities, whether they are health centers or a group of districts, we put these peer learning sites together. And over an 18-month period, they would come together for in-person gatherings, where they would use the various quality tools to do root cause analysis, appreciate what it is that their gaps are, and plan to deploy the plan, do, study, act cycles within the actual facility. So each person is going to go back to their facility with a plan. And in between these 3 learning sessions over the 18-month period, we will train coaches. And some of these coaches will be the team leaders who are based in the facility. Some of it will be leaders extracted from the health system at the district and the regional levels. They would pay on-site visits, help them to review their data, unravel management challenges, and then other challenges that the teams will be facing. And they would learn from each other. So we'll create a common measurement framework, maybe a dashboard that shows performance across all the facilities. And they could range from anywhere between 9 units or 12 units. Then comes this driver diagram, which is really your theory of what is causing mortalities. And this looks at a sub-district level, so at the community level. And the question then is, how can you accelerate reduction of under 5 mortality? That's your theory. That's your big outcome that you're looking at. And we looked at 3 things: seeking care early, providing prompt care, and there's an issue around the culture around data use, using the data for improvement and not for judgment. And so within each of these primary drivers, we look at the key health system features that we think affect this. So certainly you can appreciate that when we talk about seeking early care, it's about community-related features that you need to intervene in if you are going to be able to get people to come to the hospital early. Then the whole issue around providing prompt care when they hit the facility, it has to do with practices that are embedded within the facility. So you look at it. And then the culture issues are data, supervision, and all of that. So it's not every team that is going to work on each of these drivers. But depending on their data, they are able to identify which is their core problem, which primary driver is their core problem, and which of the secondary drivers, in their opinion, best influences that, and that they can begin to plan their PDSA cycles around. So there are all these change interventions that people will then test on a small scale, learn, adapt, whilst we collect data rigorously to show that things are really changing. This focuses really on the community bit. And here you would see a very classic example at a learning session. When they come together, we call them learning sessions, where you would have a community health nurse, a community volunteer, and a traditional birth attendant. These traditional birth attendants are untrained personnel who conduct deliveries in their communities. And this was an effort to try and shift deliveries from their community to the health facilities. And here they did a simple process map to show what happens when a woman goes into labor until she delivers in the facility. And what you see very clearly is the various gaps and the various decision points that come through. For example, when a woman goes into labor, what became clear from this simple exercise was that she needs the blessing of her husband to be able to come to the facility. Or if the labor is deemed to be difficult, they would see a traditionalist, they would see a soothsayer who would then say that this is a delivery that can happen at home or in the hospital. So clearly, the intervention was not even at the level of the traditional birth attendant. You can give her the training and all of that, but if the woman in labor inherently believes from the authority of her husband or the soothsayer that the labor needs to occur within the facility, then that is where she's really going to have the baby or have it at home. So involving the community became a critical component of the intervention. As we involved the community, it also became clear that we needed to change a variety of teaching methods. So using more pictures to educate people on anemia, birth preparedness, so that we can save for transportation when the woman got into labor, improving communication to address referral concerns, creating standard tools and protocols so that the health system will be able to document, because at the beginning of some of these initiatives, people will be referred, but without appropriate documentation of what their diagnosis was or what had been done at their respective level to be able to manage their condition. So these were really community level interventions that we focus on. But as I said, in the third wave, we also had an intervention focusing on hospitals. And again, we used that 3 delays model of early care seeking, delay in providing care, but not just a matter of the culture around QI, which we we highlighted in the community level. In the hospitals, we talked about protocol use, because in analyzing the data, it became clear that malaria, upper respiratory tract infections, diarrheal illnesses were the leading causes of mortality. And so it was good, it was important to find out adherence to protocols in these conditions. Because if malaria was your leading cause of death, then you needed to be able to intervene in that area. So again, we came up with a number of secondary drivers and process measures to be able to track performance at these levels. So you talk about delay care seeking. How do you track that? We looked at the average time of onset of symptoms in the house and time to arrival. And in Ghana, we like to just observe that television adverts would say, when a child is ill, child has malaria, child is unwell, you can start with paracetamol. And if the child doesn't respond, after 3 days, go to the hospital. So in people's minds, 3 days before you come. And now we have to shift and tell them that if the child has severe malaria, 3 days may be too long. So reducing that time became a key measure for us. In the matter of delay in providing care, we looked at, for example, average cesarean section response time, the time between identifying of a critically ill woman in labor and then actually starting the treatment, and then also in the matter of reliability in the use of protocols, mainly tracking adherence to protocol use. This is a good example where in one facility, where the bulk of the mortality had to do with malaria, you would see in the beginning here the unreliability in the adherence to the malaria treatment protocols, and how with training and interventions, the process became more and more reliable, so that over 95% of the time, children were receiving malaria treatment using the correct evidence base that was prescribed by the Ghana Health Service. So it's a very methodological process. It's very rigorous, it's data-driven, and then you pinpoint the problem and intervene at that level. So at this point, you've done a series of interventions within the facilities, you've done a series of interventions in the community, and you need to now codify what has worked and why it has worked. Because we would say that in this learning collaborative, it's not so much the evidence-based. We know what works. The key missing part is how it works. So by documenting what people did, in the previous example, the doctors did ward rounds and used those ward rounds as teaching sessions to educate on the protocols. We documented all of these things and developed what we call a change package. And it is this change package that was scaled up from over 9 hospitals in the beginning to over 200 hospitals. Was there an uptick in the change package? Sure. By the time we got to 200 hospitals, we could count that between 70% and 84% were adopting the changes that were prescribed to address the key drivers of mortality, which means that if these key drivers really are what results in the reduction in mortality in the initial 9 hospitals, then successfully scaling it up will mean impact at a higher level, which then raises the question of what the results are at each point. This is more at the level of the community where we are looking at skill delivery, the proportion of women who deliver under the supervision of skilled personnel, so midwives and other categories of staff. And here you see the control chart where from about 55%, we ended up with about 80% of skill delivery. And the important thing is to document, because if you do not document when you implement your changes, it's then difficult to replicate it or to be able to share the best practices and the lessons that emerge from this. And then in the third wave, where we started with 9 hospitals, that then became the prototype, enabling us to develop the change package. 6 out of them showed significant reduction in mortality, over 50% reduction in mortality. But cumulatively, the 9 together recorded a 17% reduction in mortality over 18 months, which was pretty, great. Inevitably, people would ask, so the 3 out of the 6 that did not show significant improvement, what were the issues? Weak management support. So management would not apportion time for team members to meet. Poor team dynamics where leaders may not involve everybody in the group. Some don't feel they are part, they cannot speak, their ideas are not listened to. High attrition, people going to school, people getting married. And so anytime you went to the facility, you were dealing with a new, cadre, and then challenges with reporting of data. So people are running cycles, they are not collecting data. So it's not clear whether your process is actually improving or not. But cumulatively at national scale, the results were pretty impressive. Looking at the total number of hospitals that we're working in, and recording a 35% reduction in under 5 mortality. And of course, I'm talking about a 38% reduction in under 5 malaria case fatality, children dying from malaria, So again, great results. And yes, we will say that the project contributed to these national level figures, because even as the demographic health survey was conducted, it bore out these results that at the national level, within those survey data, we had seen also reductions in under 5 deaths and malaria-related deaths. So I'm quite sure that the intervention, although driven from the project perspective, they're contributing to these national level outcomes that we saw in Ghana. So you've done an implementation within the prototype. Remember the Scale-up Framework. We build well, we do the setup, we test in a variety of settings. How do you then build the infrastructure that supports the scale-up of these interventions? The first one has to do with the policy. And all the time that we were doing this, there was no clear policy prescription to guide how things are done. So it continued to remain a prototype activity. At this point, the country has a national quality policy and strategy that then makes clear provisions for how QI teams are formed, the training programs, involvement of patients. So it's not really project driven any longer. It's the health system itself taking ownership for these. And again, whether some of these interventions are cost effective. And indeed, with the independent evaluation that was done, it was shown that although we had massive initial cost to train personnel, over the lifespan of the project, the 7 years, and looking at the outcomes that we achieved, indeed, it was cost effective. And it is worth looking at how governments can invest, or managers of health system can invest in their staff in this way, because the long-term benefits are awesome. Data quality improvement is always a challenge because we use routine data. The aim was to strengthen national data systems and not weaken them. So it was important that we roll out a specific protocol that will continuously compare source data to reported data in the routine health system and close the gaps by way of accuracy, completeness, and timeliness. We also created a learning network among data officers so that they would look at the indicators that they are reporting on. And it was interesting. Sometimes people report certain indicators, and as you investigate, you realize that the numerators are not speaking to the denominators. They are collecting totally different things. And this type of learning network where we are using data to improve our processes is great. And, people then understand that you're not trying to pass judgment on their work. Initially, I spoke about the rapid increase in the number of teams. There has to be a mechanism where the health system trains people with the requisite tools and approaches to be able to drive improvement. And within the context of the project, we then had to, the project that was implemented at scale had just about 23 or so project team members. But then we focused on training over 350 improvement coaches extracted from the Ghana Health Service, who then could lead future work. And they are still employed by the government of Ghana, and they are available in the health system. And within the quality policy strategy that is available, there are clear provisions for how they would intervene at the district, at the regional, and within the facilities. So the health system really is assuming ownership. And there are also discussions around incorporating some of these QI and improvement concepts into pre-service education and training, and to also continue professional development programs so that there's a way in which you constantly nourish the health system. And of course, as a result of this work, we formed an Africa-based quality institute called Ibora Institute that is now working in partnership with the Ministry of Health in Ghana to conduct trainings, to help in technical support, and so on and so forth. So this really is now a permanent structure that has been set up that is supporting not just in Ghana, but in other places, you know, in India, in Liberia, Sierra Leone, and so on and so forth. But it's African-led, and it's pretty inspiring. This is also some document that we put together, the lessons learned from Ghana's Project 5's Alive, where we try to document the various lessons in these 7 areas, whether it's HR, capability building, measurement, communication, leadership. Very practical for people who are doing similar work, and it's online on IHI's website that you can download and use if you would like. So in conclusion, I would say that in terms of the lessons that were learned, there's no need for the methods to fight. That I am lean, I am Six Sigma, I am this, I'm into accreditation, I'm into policy. They need to work together. You need a complementary approach. As Duran said, you need quality planning, you need quality control, you need quality improvement. That total approach helps a very clear transformation for your health system. 2, you need a mechanism where you constantly are training people, because if you're just waiting for people to come out of nursing school, pharmacy school, medical school before you train them, it's not as effective as if you built it into the curriculum and then you began to produce a new generation of health professionals. And recently I was in Nigeria, where the Nursing and Midwifery Council of Nigeria rolled out a new curriculum with clear provisions for quality and safety, entrepreneurship, and all of that. So pretty progressive. And the third bit is that as you engage with various levels of the health system, with managers, if you have sustainability in mind, then you need to design interventions together, and you need capability building right from the get-go. Instead of running it as a typical project, after 5 years, then you say who is going to take ownership. It doesn't really work that way. So the 4th bit has to do with data. I have not worked in any place where data has not been a challenge. So it's important that you do not take it for granted that the routine health system is robust. You need to be able to invest in improving the quality and reliability of the data systems. And 5, the health systems have structures. Hospitals have structures. They have data sessions. They have clinical meetings. So the more you can layer your intervention along these, so that it doesn't feel like you are burdening health officers, but you're augmenting what they already do, the better it will be for easier uptake. So once again, thank you for the invitation, and I look forward to taking any questions that you may have.
Thank you, Dr. Tettey. That was a remarkable experience that you have explained to us. Starting from small centers, three districts, over the period of years, expanding to involve the entire country. That was extremely impressive. And the proof of the pudding was in your showing the final results, where you were able to drastically reduce the under 5 mortality and the malaria-related mortality. Congratulations on your remarkable work. This has really been inspiring, and it is now a challenge for many of us to take it up in our own centers and carry on the lovely work that you have done. Thank you, sir. From Akio Hirata, thank you for a great presentation. It seems that people are eager to take data and indicators, and sometimes it's become more objectives rather than tools. Even the accreditation, it is sometimes becomes objective rather than the tool. How would you change the people's mindset? That is the question which has been asked.
So you're talking about the use of data, which is critical. And I think that the first thing is that there needs to be a conversation around what we need the data for. Because a lot of the time, when the standards are set, when the indicators are defined, the impression is created often by the leaders that we need to get the data to judge you, to show whether you're doing what you are doing as an accountability tool. And you need to have the conversation that then says that we are collecting this data not to pass judgment on you. We are collecting this data to drive ongoing continuous improvement. And it may sound trivial, but it's very important. If you do not change the culture, the thinking around what we collect and use data for, we always end up in a very difficult space where people do not report the accurate thing. They falsify the data. They try to look good on paper, when really children or bad outcomes are being recorded at multiple levels of the health system. So that's the first thing. The second thing is that we need to be able to be very clear in our prescription data needs. So there are management questions at multiple levels. At the national level, you may be interested in outcomes, mortality, and all of that. But the indicator that is being collected has to be appropriate at multiple levels. So whilst at the national level, you'll be interested in mortality, within the hospital, at the level of a nurse prescriber or a physician or physician assistant, they would be interested in adherence to a particular protocol that is more reflective of their day-to-day experience in a consulting room per se, or in a series of cases that they've managed. And that is closer to the outcome that they are seeing. So processes that may not necessarily reflect at the national level, but that were very critical. Again, a similar one has to do with home visits. So whilst the country may have an aim around reducing maternal mortality at the national level, if you take a community health worker, well, she's not really going to see mortality. So if you say, what is the maternal mortality at your level, it's going to be almost meaningless to her. So again, this is where you might want to say that your goal is about the number of home visits that you're able to do a day. That is a process that is more proximal to his or her activities. So getting an appropriate level of indicators is key. And the last bit has to do with creating of a learning system. So it's not proud to start in this work. A number of people would just collect the data and report upwards. They would not have time to reflect on it themselves. But where you put multiple like-minded people together, they have a common aim, they are working on similar processes, they are interrogating their own data. You create a platform where there's a constructive discussion around data and how that data is being used to drive improvement. And it is just transformational, because at the end of the day, people understand that, well, it's not about punishing, it's not about shaming, it's about understanding our systems. And it's also not about focusing on individuals, because it's the way the systems are designed that we are getting the bad outcomes. And if we want to change those outcomes, we need to redesign the healthcare delivery system. So then you change really the mindset of the people, because in some places, in many places, as a matter of fact, health workers are wired to expect inputs. So you start intervening and they ask, are you bringing more doctors? Are you bringing more equipment? Are you building new facilities? When you say no, and you say it's about changing the way we work, changing the way we think, often they are initially disappointed until they work with the methodology and they are prayed for some time, and they realize that actually the power to influence change and to bring about improvement is in their hands. They can actually achieve this on their own. And that they can then look at their data, track it, and call you at the national level and say, yes, we've seen a shift, or we've seen a trend, or something remarkable is happening in our facility. And that is when you realize that the excitement has kicked in for they as well. So it's a multitude of factors, but I think at the top, leaders must set the tone and must set the right expectations for improvement.
Very truly said. Yes, absolutely right about what your the change that is required, rather than increasing infrastructure and people, etc. Thank you very much. I would like to thank Dr. Sodzi-Tettey on behalf of CAHO and ISQua for that wonderful talk on implementation of science case-based scenario that you have just presented to us. As you can see, this certificate of appreciation is what will be given to you from CAHO. It will be sent to you shortly, and with thanks from our side. So once again, on behalf of all these participants, I would like to thank you, sir, for having taken your valuable time and explained to us step by step how your experience in Ghana has gone forward to give such great results. Thank you very much.